Abdominal pain. Abdominal pain can be characterized as cramping, dull or aching, and is either constant or intermittent. Cramping abdominal pain is characterized by pain that increases in intensity in short waves to a maximum, and then abruptly ceases for a period of complete absence of pain. Repetition of the pain occurs at intervals. This type of pain is associated with mechanical small bowel obstruction, and when clearly present, it is pathognomonic of that condition. Constant dull or aching abdominal pain is usually caused by distension or edema of the wall of a hollow viscus. Pain from stretch of the capsule of the liver and the spleen may also be perceived as dull or aching pain. Each individual perceives pain intensity differently. The intensity of pain in an individual patient can often be assessed by the way in which the patient physically responds to it. Patients with peritonitis, somatic pain, invariably lie still, perhaps on one side or the other with the knees and hips flexed, whereas patients with pain arising from the hollow or solid viscera, visceral pain, do not lie still but constantly change position or move about. Visceral pain, resulting from stretch of smooth muscle, is localized in one of the three midline zones of the abdomen: epigastric, mid-abdominal, and lower abdominal. This midline zone pain, the sum of pain from the right and left splanchnic pathways, is poorly localized, covers several body segments, and, depending on its cause, varies from dull, aching, constant pain to cramping pain. Nausea, vomiting, pallor, and sweating are commonly associated with visceral pain. Gastrointestinal complaints, anorexia, nausea, vomiting, altered bowel habits, hematemesis, hematochezia, abdominal distension, back pain, genitourinary problems, urinary complaints, foul discharge, thoracic complaints, chest pain, breathlessness, palpitation, and constitutional symptoms, fever, weight loss, may be associated with pain, which can give clues to diagnosis. Patients with peritonitis often remark on increased pain, with jolts or bumps in the road. Peptic ulcer disease may be exacerbated by eating. Mesenteric ischemia may be precipitated by eating, as can the pain of intermittently symptomatic gallstones, often associated with fatty meals. Constipation, UTI, stress, full bladder, and food intake are some of the aggravating factors. Antacids relieve burning pain due to gastric acid production. Antiemetics, like ondansetron and metoclopramide, are useful in remitting nausea and vomiting. NG-tube is essential in patients with small bowel obstruction to decompress the stomach and provide symptomatic relief. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED, the easiest and fastest way to take advanced clinical history.